Leaving school, loss of a job, divorce or separation may be similarly be helpful and explains what is going on for this patient, and it can clarify if this patient is borderline state or borderline or bipolar disorder. The family history of psychiatric illness provides also a clue to an individual genetic predisposition, but of course does not determine diagnosis, and it is not conclusive. A detailed family and social history that provide evidence of the individual's function in a school, work, and interpersonal relationship is more relevant. One of the very important clues, abandonment and identity issues, very, very essential to be diagnosed in BPD. Fear of abandonment, often an undue fear that those important to patients will leave them. Patients may go to extremes to avoid being abandoned, even when the threat is not genuine. So this is also one of the features, cardinal features, on behalf and increases an added weight to diagnosis of BPD. Patients with BPD often struggle with identity disturbance, leading to them to wonder who they are and what their beliefs and core values are. The mood lability, the time course of changes in affect or mood swings, also may help to distinguish BPD from bipolar disorder. We know that BPD, they have attachment detachment. They rapidly attracted to people and rapidly distracted from people. They are attached and detached. And also they have intense love and intense hate relationships with others. The mood reactivity can occur within episodes of bipolar disorder, although episodes may occur spontaneously and without an obvious precipitant or stressor. So we can reach a clinical point, use the patient life story as a scaffold to determine if borderline features occur only during mood episode or they are enduring pattern. We reach a clinical point, recognizing BPD can help the patient to understand his or her history and to encourage referral for psychosocial treatment. Another clinical feature, impulsivity. It may represent more of an essential feature of BPD than the affective instability or mood reactivity, and may be of particular diagnostic relevance. And we overemphasize image. How can I do this? This is the most important of my presentation. And I can say clearly, it is the message of this presentation. What can I do and what action can I take for this? We are going to draw an illness monograph for the patient. A horizontal line describing above that line what is going to the patient during his lifespan. And I'm going to divide this line by years. For our patient, he started by heroin addiction, and he came to the clinic by misuse of substances, particularly heroin, but he cured and recovered, and he quit. And then he restored his studying, and he got married. He was jailed after 2 years for a reckless behavior and shouting at a cop in the street. And he had his first divorce within 3 to 4 months. Then he regret this behavior and solved it all, this problem, and restored his marital life once more. He had a similar episode of jail due to reckless behavior, reckless driving, and shouting to the cop. In the same season of the year, the same happened for the same time in the previous history. After this, he regretted his behavior and he fulfilled his master's degree, and with great success. After graduation and the history became so clear, the patient started lithium and olanzapine. For a while, the symptoms of hypomania and mania quite apparent. When the symptoms of depression emerged, he was shifted to quetiapine, and he restored his marital life, and again he now is a stabilized condition for the last 3 years. This is our history and how the illness monograph divided the longitudinal history of the patients in 2 parts, and we found that in relapses he has these emotional bursts and emotional instability. Why we are going to differentiate in diagnosis? This will affect our treatment implications. Yes, I will say a brief word about this. We have definite algorithms for the treatment of bipolar 1 depression, and another algorithm is for the treatment of bipolar 2 depressions. And as you know that this algorithm changes from time to time according to the American Association, Psychiatric Association, Canadian Psychiatric Associations, and European associations. And sometimes we have protocols and algorithms adopted by certain hospitals and certain protocols according to the availability and the evidence-based data for it. For this algorithm adopted in Spain by Bipolar Center, after extensive and exhaustive research, they started that algorithm for treatment of bipolar 1 start with quetiapine around 600 mg for about 8 weeks. In cases of bipolar 2 depression, you can start with lithium and quetiapine or lithium alone. Step 2, for bipolar 1, you can start for treatment of resistant bipolar 1 depression, use olanzapine and fluoxetine, or you can increase the dose of quetiapine, and so on until you reach the use of ECT in both disorders. The borderline personality disorder, we have steps in practical evidence-based. They are easy to use. Systems, training for emotional predictability, and the problem solving. We can sum it up or make it as anonymous. We can make it as word, summed in a word, steps. The patient skills taught in steps. Some skills I'm going to teach my patient, the borderline patient, these skills: awareness of the illness, understand what is BPD is, reframe the BPD, identify and challenge the dysfunctional schemes, emotional management skills, distancing, provide distance from emotional intensity, for communication, describe and define feelings of physical sensations, thoughts, filters, actions, urges, and behaviors, challenging, identify distorted thinking and deep alternate ways of thinking, distracting, identify and engage in behaviors that lower emotional intensity or assist getting through an episode without restoring or damaging. To continue in steps, 12 weeks of group meetings or sometimes individual, managing problems, identity and define problems, then plan and carry out action steps. Behavioral management skills, Setting goals, identify specific goals, problematic behaviors, eating balanced diet, sleeping, good sleep hygiene, exercising regularly, regular leisure activities, physical health, abuse avoidance, and abusive behaviors as self-harm and substance abuse and gambling, relationships management, identify and determine the strategies to develop healthy. For our patient, our case we presented in the beginning, he passed into some of this. Sometimes we use this comics drawing to simplify the matter for the patient, how to go through these steps and be aware of his illness. But when he finishes these steps, when he or she finishes these steps, we will continue with follow-up stairways. Stairways also is a mnemonic for stairways. S, setting goals, trying new things, oriented toward long-term goals such as obtaining a degree, employment, anger management, impulsive control, relationship management, writing a script, identify and preparing for future stressors, assertiveness training, and your choices, making healthy choices, and staying on track. These are the stairways. We want and we have to remind bipolar maintenance treatment goals: prevent manic or depressive relapse. These are the goals. Reduce the subthreshold symptoms, reduce the suicide risk, reduce cyclic frequency, reduce mood instability, and improve functioning. So the patient is stable in medication. You have to fulfill all these goals and all these treatment goals. And this you must be sure during your follow-up with your patients in your outpatient clinic. Here is the algorithm for the management of resistant bipolar depression and the explanation for it. And here is the treating depression of bipolar disorder and the algorithm, whether you are going to start with any of the new FDA-approved new generation antipsychotics together with lithium or full dose of the medication. Here is the mood stabilizers and novel antipsychotics in the treatment of borderline personality disorders. They are not fully approved by the FDA and they are considered to be off-label medications, but they are very helpful in certain circumstances for a brief periods of time and in low doses as well. This slide I want to conclude by to show how intense is the emotional instability for patients of borderline personality disorder and how the swings of emotions ranges during the same day, sometimes during the same hour.